not connected. I can't control. Okay, so bifurcation stenosis. I want to say that this is a heterogeneous lesion. It's not a single lesion. So when we say bifurcation stenosis, it's not just one thing. It can involve the right and left main branch, including with the MPA, it's almost like a trifurcation stenosis. It can also involve the lobar branches in the upper and lower of the right and left main branch. It can also be a lobar branch with a segmental branch adjacent to that area of stenosis. You can also have combination stenoses. You can also have general hypoplasia, so therefore it's not just one vessel. You find this in the Williams type syndromes, the allegials, similar to what Dr. Sung-Ho Kim showed earlier. You can find this in the postoperative patients or some of the single ventricle variants. They can be some of the most complex anatomy to treat. So here's a paper from Toronto back in 2003 showing the different types of stenoses. What we're talking about are these vessels here, where you can either have the type 2A, 2B, where it's a trifurcation stenosis, or down into the lobar and branch stenosis in type 3s and type 4s. You can also, and these can also occur where you might have to deal with some bifurcation problems. So here's just an example of some bilateral orifice stenosis. The first one was a transposition switch. You see the stenosis at the distal MPA by the orifices. And here's another example where in the caudal view, you see the stenosis. They're right next to each other. You can imagine if you put a stent in one side, you'll jail or compress the other side. It could be discrete like that. Here's a very complex looking trifurcation stenosis. These are lobar stenoses. Here's one that's the lobe and also the right upper lobe stenosis, along with a proximal LPA stenosis. You see this very tight stenosis. This is less than like a hair of a stenosis. The whole lung is hypoplastic here. And you see how that there's some major branch off that, so trying to stent this could be a problem. So here's a Williams type picture where, again, both sides are truly hypoplastic. Now, one of the problems with stenting the bifurcation stenosis is that you want to make sure the stenosis reaches the ostium. So if you don't want to jail the other side, you can end up putting a stent like this. So while you can open everything up, just the very end part, like here, is this part that you leave a stenosis. So that's very hard to position the stent. Of course, if you bring it across the stenosis, you can imagine now when you're trying to go to the other side, this part of the stent will jail the entrance to the other side. So this is a problem. Same thing, if you go on the other side, you're going to have the same problem. So this is a situation where you have to put two stents in at the same time, simultaneously, so you can protect the entryway to both sides. So you can go this side and to this side for future rehabilitation. This is a paper we wrote a while ago with one of my fellows when I was back in Baylor. We looked at these simultaneous stenting in bifurcation stenosis. 49 patients. You see that the gradient, the gradient went from 37 to 9s. The RV to FA ratio dropped from 3/4 to about half systemic. The diameter is more than doubled. Overall, the complications are quite low, even though it can be very complex, because it does involve positioning of two stents, two balloons going up at the same time. The follow-up data was available for 38 of those patients, and you see that many of them still require further intervention. So it's not a one-time deal. You have to go back and touch up on things. But overall, there was no complications. Some of them required just angioplasty alone. Others required additional stenting because of the complex stenoses out further into the branches. And several of them actually underwent palliative surgeries for other reasons, but nothing was required to deal with the branch stenosis here. The conclusion of the study is that simultaneous transcatheter placement of bifurcation stents can provide immediate gradient relief of the bifurcation stenosis in both the proximal and the branch PAs and reduce RV pressure, and that further interventions through these stents can be done reasonably safely with no additional complications. So I showed you this picture before. This is a switch. You see how complex this stenosis is here. So you start by using 2 balloons. Now, I like using 2 balloons because, number one, I'm testing the stability of the balloon first. I also want to see what my hemodynamics are. If the blood pressure drops very fast, I might have to say to myself, I have to work very fast. If the baby or the patient can tolerate it for 30 seconds, then I have a little more time. So once I've tested the stability of the balloon and the hemodynamics, I have both sheaths up there, and both stents are gone up, and we do this simultaneously. And this is what it looks like afterwards. So here's another show that sometimes the caudal view is the most important view. So if you don't see the proximal stenosis well enough, put it to a caudal view. Then you can see the separation. And here you see the 2 branches are right next to each other. And so, of course, you can do one thing. You can put a stent in first. Now, you see that there's wires to both sides. There's a sheath to both sides. In fact, there's a stent in both sides. But you don't have to go simultaneously. You can go with one first, and then with the balloon up, have your second operator inflate the second one. Of course, when both balloons are up, you're blocking things completely. But at least you buy yourself a few extra seconds by going one first. Now, what's important is when you further dilate, you also have to dilate simultaneously. Otherwise, you can imagine the balloon would then compress the other stent. So this is further dilation going up simultaneously. So the initial implant you can do with one and then followed by the other. But on the follow-up, you have to go bilateral. Otherwise, you'll compress the other side. So this is the post after that. Again, you see that the caudal view is really useful to look at the proximal branches. How about lobar bifurcations? Again, sometimes you have to double balloon and double stent the lobars from upper to lower lobe. And sometimes we find that the open cell can be very helpful, and I'll show you examples of it. Here's an example. I think I've shown this in the past in other conferences. Here's a severe, this is a unifocalized MAPCA, severe stenosis. Here's 1.5 millimeters on the lower, 2.3 in upper, so you know that this is pretty bad. We balloon it, you see the waist there with a 6. So that's why I'm not worried about the 4-to-1 ratios. This is a 6 millimeter balloon going up, lower lobe and upper lobe. You see the stenosis there. We went ahead and put balloons in and inflated it on 8 millimeter balloons. And so this is the post. Now notice the distal perfusion. It's much better than before. Now granted, this is still not very big, but you've gone from 1.5 to 5.2 millimeters, and you've gone 2.3 to 4.3. So therefore, it's better, it's not perfect, but I want the stent to endothelialize, to be stabilized, and I can come back to rehabilitate it. But the first thing is to put those stents in first. And so this is the this is about 3 years later forecast. How much bigger they are? You've gone from 1.5, and in fact, the lower one went to 9 millimeters. And so how much better it's grown over that time. But you do have to bring them back multiple times to touch up. But the first thing is to put those stents in. Here's the example I showed earlier, again, in one of the samples. You see how the vessel is smaller than the catheter itself. It's a 5 French catheter, and this is probably less than 1 millimeter. So here we actually put in 2 stents. Again, sometimes when you get to the segmental branches, the lateral view is better than the AP view. See, the AP, you can't, they're superimposed, but the lateral, you see it separate. And you can see how we can put 2 stents in. Now, at that level, you don't have to use the big adult stents. You can use the smaller stents because that's the segmental branch. So they're not going to get to 18 millimeters. At best, they'll go to maybe 8, 10 millimeters at that level. So this is the post. Again, so here's the lateral. See the difference from the vessel being smaller than the catheter, now it's much bigger. And we don't see the dissections there. But again, you have to test it first with the balloon, test inflation first. Again, this is 8 months later. We further dilated it. Again, it's important that when you deflate, you also have to deflate simultaneously. Imagine inflating both stents at the same time. But if one deflates before the other, then the balloon that is still undeflated can still compress the other side. So you have to tell your 2 colleagues to 1, 2, 3, go. So you have to deflate simultaneously as well. Oops, sorry. So this is that same patient. You see the progression from 0.5 millimeters to 6.5 to 7.2. Now we know that we have to bring these patients in over time, but you see already there's a progression from less than 1 millimeters up to 7 millimeters. See how much better the distal vessel is now. To me, it's really important to do them when they're young, because remember, 80% of your pulmonary growth, the parenchymal growth, occurs before you're born. before you're 2 years of age. You have another 6 more years. By the time you're 8 years old, if you wait too long, the growth potential of the cells in the lungs is gone. At that point, only the cells get bigger. So you actually want to do this earlier so that you can promote more of the smaller vessel growth. So it's very important to be aggressive when they're small. Here's another example, truncus repair. You see how tight it is? Again, there's 2 major segments that I have to work with. The stent had been put in on the other side. So you look at the angles of this. Again, if you try to balloon one or stent one, you can easily jail the other one. And so we went up, do a double balloon. You see there's a waist there. You test the stability of the balloon. Then you went ahead and put the, run the stents in. Again, this is just the angioplasty. It's improved, but it's not good enough. Right? So then we went ahead and put 2 stents in. Again, you see how we put in 1 stent first, inflate that, but the other stent is ready to go. And so then one goes up and then the other goes up together. And I actually don't mind to see a little waste because that tells me exactly where the stenosis is so that I can use that for the future. So you don't have to eliminate the waste completely. Have a little bit there so you can actually see how the stent will position. So this is the post of that. Again, this is a 2.45 millimeters, and you see how much bigger it is already. Okay, this is what happens when you have a branch stenosis where the RPA has a stenosis, but it goes across the upper lobe. So here is what happens when you put a stent in. See how you can compress that? Sometimes you have no choice. But sometimes you have to think hard about how to deal with this ahead of time. This is where having the open cell stents comes in. So the Mega LD stent here has an open cell. I'll show you that you can actually inflate a balloon next to it and actually increase the size. So you can actually, even though you jail a side branch, you can still go through the side and open up the side branch. So here's a 3D rotational angiography. You see the stenosis here. There's an upper lobe that's right in this region. So here we are putting a stent in. So we put a stent in, but we ran a wire through that. So now, first of all, we ballooned that up first, then we stented it, and you see how this is what it looks like after angioplasty. So then we went ahead and put a stent in. Now, you see how it's jailed this, but now you can actually run your wire through that, and you can inflate this and open up the cell. See the waste right there? That's the waste from the orifice and the side branch, the side of the stent. And so now when you take your picture again, you see how you see the orifice right there. See the orifice right there? You can also see it right there. So these are nice demonstrations of where you can still open up the side cell to allow a good flow to the side branch if you plan to jail that branch. Now, I know I've been talking about pulmonary artery, but sometimes the pulmonary veins can also have bifurcation stenoses. So here's an example of a patient who only has 1 femoral vein. So we have a problem. So you've seen up to now, we use 2 sheaths, but here we have a 1-on-1 sheath. We crossed the ASD, and now we see the stenosis right here. Of course, there's 2 branches coming in. So again, you can imagine putting a stent here. You will jail one of the branches. So in the context of pulmonary vein stenosis, that could be a major problem. So we end up using single sheath. This is an 8 French sheath. You put 2 wires in. And I find that if you use an 8 French sheath, you can actually put 2 stents in at the same time through the same sheath. So here's the sheath, 8 French. Now these are small stents, and so there's a limitation. But this kid was very sick, so I know that I don't have much of a choice right now. So I know that in the future, if he grows to a point where he outgrows the stent, I think we've already done ourselves a service to him. I can always try to fracture it later on. So here's 2 stents going up. Again, the first one goes up, and then the second one goes up while the other one is still inflated to protect both vessels. And you see that, that's the distal one. Here's the proximal one. So we put a stent further out, and here's the proximal. See how the first one goes up, and then the second one goes up. Again, you need 2 operators to help you as you're keeping everything stable. So this is in the pulmonary veins. And now you see how much better flow is. This is the pre to one lobe. Here's the pre to the lower lobe. But we're able to open this up. Again, this is not a good size stent, still small, but there's 2 of them there protecting that orifice. And this is what it looks like. That 8 French can actually take through 2 of the coronary stents. And they can go up to like 4 or 5 millimeters. So here's an example. This is the same patient 2 months later. And when I do them that small, I always want to check to make sure there's no restenosis early on. You see the flow through the stents in this region right here. This is a wedge injection showing there's pretty good flow here. And there's the wedge injection through the stent itself. So how about a trifurcation stenosis? This is actually from Dr. Mullins many years ago, where he ended up putting, there was stenosis at the LPA, a stenosis in the RPA and a stenosis of the right middle and the upper lobe here. And so you see there are 3 wires here, and the orifice is actually pretty close. So the first thing he did was to put a stent in the LPA. Then he double stent the RPA and LPA proximally. Then there's still stenosis in the upper and middle lobe. Then we double stenting in the up region as well. This is probably 2000 or so, year 2000 or so. And so this is what it looks like afterwards. So there are 5 stents in here, open up everything. Almost 10 years later, Dr. Mullins retired, and I inherited the patient. So here we are taking the picture. See how the surgeon had put a new valve in. This patient is an adult at this point. And so because of the closely related orifice of all the 3 regions, we actually have the triple balloon disc. So you see there's a balloon into the upper lobe, middle lobe, and the LPA. And all 3 have to go up at the same time. But in adult-sized patients, you can do that. This is what it looks like afterwards. So there's a lot of technical challenges in the bifurcation stenosis because the angiography cannot often profile things perfectly because there's superimposition of the vessels. The 3D angiogram actually can be very helpful. Sometimes you need multiple angles, and sometimes you need 3 operators. And if you do a triple balloon, you need 4 operators, 1 person to stabilize all the wires and 3 people to inflate. There's certainly a higher risk of the stent malposition, so therefore precision of the stent implantation is really important. And you also have to worry about balloon rupture, because if the stent edge punctures in the other side, that can be a problem. That's why I like to pre-dilate to test it first. Angles, the advantages is that with the hybrid approach, of course, is that you can do this, and even if the balloon rupture, you can take it out. You have very precise positioning. You can adjust the stent if you want. You can actually trim the stent, as we mentioned earlier, especially in the MPA region. And you can do this in very small kids. But the disadvantage is still an operation. So again, you see how we put the 2 stents in. The surgeons remove the middle part of the struts, and then the lateral stretch it open. So now you have a single large orifice to work with in the cath lab. So this is a very important strategy to work with your surgeons if you plan these out in the future. So now the catheter can go to both sides. So here there's an example of one where we put in 1 stent, we put in the other stent, and now you take a picture afterwards. You can see how this is what it looks like in the post-op x-ray. And now, of course, afterwards you start to rehabilitate this further. And this is you created a new MPA orifice using this technique. The stents actually can be cut very easily. It's not very difficult. The surgical scissors are very good at this. So here we are further dilating everything, and this is what that looks like afterwards. I think we showed this earlier. See that? Here's an example of very severe MAPCIS here. See how tight this is? This is horrible. So we end up putting stents in distally, and then we put in stents in bilateral, proximally, and further dilate, and you can open up things. This patient actually was severe RV dysfunction at the same time too. So you see how that you do this over time, you can slowly rehabilitate these vessels and decrease the afterload. This is what it looks like initially. These are horrible vessels, especially because they're MAPCIS, but you're able to slowly recruit the distal branches if you're aggressive early on. This is an example I'll show you the last lecture. You see how severe this is after truncus. This thing is pretty small. This is a 6 French catheter. So this is about the same size as this catheter, less than 2 millimeters. There's a long branch. This is a tough situation because the baby's small. It's very difficult to put bilateral stents into a small baby. So again, because it's so short, we can take the stent and cut it into a smaller length, and then we can actually put 2 balloons, mount the single stent on 2 balloons, and now you could put 1 wire into 1 lobe, 1 wire in the other, and position the stent so that it doesn't jail. The beauty of this in the open system is that you can see exactly where you're putting it into. So this is the angiogram just overlaying so you can see what it looks like. One wire to the upper lobe, the other one to the lower lobe. The stent will never jail any branch. It sits in the proximal area. And so we do this in the operating room, and then we actually added 2 more stents distally right there. And so this is what it looks like after. We actually put 6 stents in. I'll show you there's the proximal one that was cut. Then you did the simultaneous inflation of the upper and lower lobe. Then there's another one, the other half of the stent, so save me some money. You just use the other half to put in the proximal left, and then 2 more stents out there. And this is what it looks like before, and this is what it looks like after. I can't imagine the surgeons would be able to fix this just with a PA plasty. 15 months later, and then we further dilated this, and this is what it looks like afterwards. So let me just show you, let me just summarize that the anatomy of the bifurcation stenosis can be complex, involving distal MPA, orifice of the main branch pulmonaries, the lobar branch, the segmental branch, as well as general hypoplasia of the entire pulmonary arterial tree. Technically, these are challenging, but there are techniques that you can use to successfully put in the stent, including hybrid options. You need accurate angiography and as well as precise stent positioning, and the immediate and long-term results are promising. Thank you.